There is always a first. I've done some shows before, but today I've never had a two amazing couple, powerhouse couple, and on the screen. So AI is going to be really confused by the transcript of this, but this is great. I'm so glad you're here, Nilesh. Would you introduce yourself just briefly before we get going, and then as well as your amazing better half, as we should say?
Absolutely. Name's Nilesh Bhandari. I'm a founder and CEO of Advanced Health Academy. I've been across the spectrum in technology and healthcare technology for the last 20 plus years. And yeah, fortunate to be here. Thanks for having us on board. And then Dr. Payal Bhandari, you want to go ahead?
Yes, I've been a clinical physician for over 24 years, trained in family medicine, practiced traditional primary care for over a decade, and then shifted to integrative functional medicine, really focusing on how do you use data to understand the root cause of any disease, and how do you then take that data that combines the research and the practical application to really transform people's lives.
Wow. I'm glad you guys are here. And I think all of us as patients really want to get at, better care. And so Nilesh, I know we're looking forward to having you on a second time. Want to make sure we focus on the right topic. You guys got some really super cool backgrounds across the board. So what do we really want to focus on this conversation today?
Yeah, I think a big issue that we see out there is the use or the lack of use of the best clinical data and what it takes to drive clinical decision making most effectively. The field of medicine feels like it's turned into such a rapid fire response that clinicians have so little time with patients. And as part of that process, how to bring the world's best insights together at the fingertips of patients becomes harder and harder. And so how do we do that at scale? How do we provide that sort of information so that clinicians are empowered to do beyond the science of medicine, to be able to come back to incorporate the science of medicine with the art of medicine and the art of healthcare, and bringing those elements together, which, in this industrialized age that we're in and mechanized age of AI and automation, it becomes harder and harder to pull that off. And I think in actuality, with automation and AI, we can drive better data insights if we do it intelligently. And so I think that's really where I would like to steer some of this conversation, because I think it has the biggest impact for the healthcare industry writ large.
And that's really going through, we'd like to go through a little bit of the case studies, Dr. Bhandari, with your practice, some of those insights, those journeys, without mentioning names, but would that help give the insight of that root cause where you get to?
For sure. I think it's about how do you take data and make it come to life, because that's really what each one of us are dealing with, where we're all patients, and lab tests are done every day, thousands and thousands. And so probably in someone's lifetime, they're going to have labs done, at least in the United States. And so when you don't actually understand what your data means and you're fully dependent on someone else to figure it out, there is a skewed perspective, because you are the expert of your story. And when the model is designed where there's not enough time to hear out a person's story, and the data really kind of brings a lot of information to the surface, we lose sight of what does this really mean and what do I do with it, right? And I think we are in an interesting era where we can harness that data with technology to really drive amazing insights that can transform people's lives, but also fundamentally shift healthcare from being reactive, terrifying, anxiety-provoking, treating humans like you're still a mystery. Here's a diagnosis. Here's what we think your solution is. But the approach is that more than 40% of the time, the diagnosis is incorrect, and that the solutions are designed for the general population, not for the human. And we really don't differentiate between sex, ethnicity, and race. And that is a big issue, because people's metabolisms and how they operate, they are expressed fundamentally different. And we are in an era where science has actually uncovered so much of that data, but research and practical usage don't really come together very effectively, and it takes decades. And so I think that when we can take those case studies to actually make it come to life, then we each have an aha moment and we feel empowered with how the data is actually making us feel safe versus right now you see the data and you don't know what to do with it and it scares you.
I'll just give a simple example on that. So the most common issue that we face across sort of the US, a lot of chronic diseases, but one is the top two I think about are cardiovascular disease, or now called cardiometabolic disease for good reason, as well as diabetes. And right now, by and large, if we say LDL cholesterol levels are high, we're basing that on a curve that is based on a national majority population. That is based on Northern Western European descent. Male eventually applied to females, which took a long time for that to happen, but at least that's now happened in the last couple of decades. Well, when we look at that curve, that's based risk profiles for that, call it ethnicity at the end of the day. When we look at other ethnicities, we know the science has shown, clinically proven, that the risk profiles are different for someone of different racial and ethnic backgrounds. And while that's the case, labs today are going to report based on national demographic, like every lab around the world does. And they're going to base that around not only the population majority, but also based on the equipment and the reagents they're using to be able to build out that curve. The question is, how does that curve shift based on the individual patient, what their sex, age, racial, ethnic background is? Because the data shows that appropriately to say the risk profile is different. Simple example, I'm of South Asian descent, born and raised in the US, parents are from India. When I look at a high LDL cholesterol level, which I am guilty of, how do I think about that risk profile? Do I base it on my lifestyle and having been born and raised in the US and living my entire life here? Or do I base it on my genetics, my racial ethnic background based on Indian profile? The curves look different. We know, the research has shown, even in the United States, that the probability of a major acute event, an MI, a stroke, at any elevated LDL cholesterol level is 50% higher for a South Asian male versus someone of Northern Western European male descent. And how do we take that into account going forward? And every ethnicity has got a little bit of a different curve there. How do clinicians take that into account appropriately to ensure that the care is appropriate for that individual? So the data is out there. The question is, how do we apply the tool to make that happen?
Mm-hmm.
Well, I hope you're not asking the answer from me.
Well, I think that we're getting better at this. We have tools like what we've developed at AHA. There's other tools out there that are pulling that information together. But the bigger question becomes, now that as we're moving into this age of AI being trained on historical data, we're seeing more and more research out there that's showing that the level of clinical bias that has been there historically is now being really codified into AI models in a way that is showing bigger concerns, or codifying those concerns directly into the models that's then driving clinical decision making. That's a concern we're worried about. That is something that we want to make sure that we think about more holistically. Say, wait a minute, let's undo the ills of the past. Let's not bring that forward if we're going to be intelligent about this entire process. The hardest part of that is that the training data has that built in, and that's what we're training AI models on today.
So not only, I mean, it sounds like it's just going to be making things even worse at this point until we put the brakes on and section it off and get that data designed right from the get-go. I
don't know if it's going to make it worse. Definitely, if we continue down this path where we're blindly looking at it, that's one thing. But luckily, everyone's thinking about clinical reasoning within the age of AI. Different medical systems are thinking through how to incorporate that appropriately. And there are tools out there that are rules-based, decision-based, that is focused on how do we undo some of those elements where we've had the bias in the data historically and think through that. So I think we all need to be smarter about it. And with this explosion of data, the question is, how do we get to insights that are unbiased over time? And using tools that are specifically focused on that, I think, is a critical part of making it part of the broader portfolio of decision-making sort of support tools to help ensure that clinicians don't bring that bias going forward.
So what are we doing now to do this?
Well, we've got a number of different tools out there. I think we're able to capture more of patient history in a better way with the AI ambient scribe tools out there, and using that to then use AI intelligently to think through, well, what is actually some of the undertones that are there, hopefully, to ensure we can capture that appropriately. Secondly, we have tools like Advanced Health Academy, where we're looking at lab tests, the most empirical data that's inside the body, or best assessment of the patient data, run against a set of rules that ensures that we are taking the latest science, not decades-old science, and personalizing it to that individual's demographics to ensure that we've got the most comprehensive interpretation, lab interpretation for those patients. And in doing that, helping them to drive decision-making appropriately. So tools like ours, tools like others are helping to bring these sort of this hodgepodge of solutions together in a way to make that a much better solution out there. I mean, Dr. Payal, you've seen this in your own practice when you think about what you've seen with the patients, and part of the co-development of AHA has been exactly this. How do we drive this in a way, especially for medical mysteries, which you spend so much time dealing with patients from around the world?
Yeah, I mean, the data doesn't lie in the sense of the numbers itself are very clear. It's the interpretation of the numbers which can be skewed. And what I've learned in my career is that the deeper you go in understanding the data in terms of really aligning the science, allows us to actually think broader from a move away from a reductive approach. So Nilesh gave the example of like cholesterol, cardiovascular disease, but that's not really science-based in the sense of you're not really understanding what is actually cholesterol. If you find it in the blood, what does that really mean? There are many more like physiologic and pathologic issues that are going on. And so when you understand it from that perspective and you really hone in on precisely what does that biomarker mean, and then you can go upstream to say, okay, these are all of the organs, all of the pathways that were actually involved for this number to show up on the lab result. Now that's tied to that human being. What we have in medicine is we have a drive to diagnosis, and then the diagnosis is driving to the treatment. That doesn't actually make logical sense. So when you can separate it out and say, yes, we need to drive to the diagnoses because that's how clinicians are going to get paid, right? Is you give the diagnoses and the payers based on how sick the person is how you're going to pay somebody. But a human being wants you to treat them based on clarity of the data. And what I have found is that when I separated those two out, I could give those diagnoses that would drive the highest insurance reimbursement, because that's really critical from a business model. But for the patient, they want to understand, how do you take that data to actually create precision on the treatment? And the treatment has to be aligned around not just what medications, but there are lifestyle factors that are directly driving it. Because if you think about our current medical model, we drive diagnoses to like, here's the treatments, but the treatments that we mostly spend energy on are pharmaceuticals and surgical, or more diagnostic tests. But if you look from the data saying, okay, this person wasn't necessarily on these drugs, and like they're eating, they're sleeping, there's something going on. The data, if you can take from the angle of like there's real pathology, then go upstream to say, what is it that's not working that we can then tap into and address that? Because if we don't address it from a root cause, then the fundamental problem is going to getting bigger and bigger and bigger. And so our solution, we have to fundamentally shift that pathway of how we're addressing. And I think with AHA, that's kind of how they've created the models, which is harness the deeper understanding of each individual biomarker, go upstream to connect all the dots in terms of how are these organs actually, what's the health of these organs? Then bring the diagnoses, because that's a really critical piece for clinicians. And then the treatments are customized to the actual laboratory data, right? So it's a really different, much more holistic approach. And that really is what's going to drive results for everyone's, what incentivizes all the players, right? And you have to recognize that.
So structurally, I guess with your integral functional medicine, you have a approach where you're not, I guess, blocked by traditional medicine. What is it currently? What's the blocking of letting the right practice happen right now? Structurally, that has to change.
Structurally, clinicians are at the mercy of payers.
Mhm.
And with payers, they are incentivized to demonstrate people are very, very sick, and that insurances are predominantly you get a higher reimbursement when you push for drugs and procedures, right? But that isn't always aligned with what the patient needs to actually understand what's going on with them and get them better, right? And so that's one thing that's an issue. We also we've had an explosion of data where we've got lots and lots of diagnostic tests. We've got lots and lots of like invasive solutions, but that has not led to people actually driving better health outcomes, right? We've got massive epidemics in so many chronic complex diseases that are predominantly lifestyle based. And so if you look at this paradigm, we keep focusing on more diagnostic testing, more of these like general population based solutions, but there is a fundamental mindset that has to shift.
Well, I mean, part of that also comes down to the industry structure.
Yeah, it's just designed this way, right? So to realize providers have a different incentive, patients have a different incentive, and payers have a different incentive, right? And that's what it is. And so if you want to change it, we have to kind of look at companies like AHA that are really looking outside the box, who are actually saying, how do you create a model that actually works for all the players? Because we're not going to change the system from within. We're going to drive it in a way that is actually a win-win platform.
I mean, I'll also add to that, I think the most innovative solutions out there that are driving the biggest cost reduction, but also the best patient outcomes, are models where they're at-risk healthcare models. And when they're fully at risk, we see that the alignment changes towards more sort of preventative services earlier, more proactive action, more primary care coming back into the fold, because it can help not just quarterback complicated situations, but also understand how to keep people out of those acute situations completely, to drive down the cost of care overall. And so I think there are tools out there that can help, like AHA, but I think more importantly, these at-risk models and seeing the explosion of that, but how profitable they are, I think, has been very telling. And using any of the major ones as case studies, whether you think about Oxnard, you think about ChenMed, you think about the hundreds of others out there that are making it work. Most of them have done it out of necessity, but they've shown that when we can return back to a combination of the best digital tools out there to bring the data to insights out there, number one, but then number two, be able to drive that at a primary care level, that's where I think we can start seeing cost reductions overall. Now that obviously, industry structures and sort of models are changing where that now is being shared appropriately with payers, but that's exactly, I think, the point. It's only we're going to get there when we're seeing these escalating so quickly.
It seems like you have a really exciting technology that could work really well with the ACOs, the value-based care, the organizations that are on the hook with that cost containment, because they're not wanting to spend $60,000 for diabetes, whatever that is. And rather they want a whole, that insight to really holistically, effectively, do we want to share a little bit more about that at that structural level, and then go on more to, I think, from your perspective as a clinician, I think both those could be really helpful.
Yeah, just from a structural perspective, the way Advanced Health Academy works is when labs are going to be ordered as normal per annual physicals and annual tests, and as those lab results come into the EHR or into whatever system you're running, we can go run an automated interpretation based on whatever the lab results are. That interpretation provides a number of different elements, provides root cause analysis of what's happening, what the labs are showing overall. It's driving individualized assessment of each one of the biomarkers based on the patient's demographics. So help identifying the risks that are probably disproportionately affected when we think across a national population average. Third, we're also talking about how well the different organ systems are functioning and what's driving that. Instead of just talking about the different medical calculators and a lot of the complexity on the hood, we've simplified it so folks can understand it from a high-level biomarker perspective. When we have these abnormal biomarkers, those are primary causes in addition to everything else, but we've simplified that out. And then lastly, we've given the appropriate ICD-10 diagnosis code so that downstream coding and billing can better provide the most accurate assessment for coding and billing, which really is driving most appropriate coding and billing, which is driving appropriate revenue reimbursement. I'll put it that way. So that's the highest level. Beyond that, we're also able to identify issues as they're emerging. We're not waiting, to be able to wait till stage 4 of disease progression to be able to say, wait, now these values are abnormal. Why are we not looking at these stage 3B and 3A? And so we've got warning zones that are appropriate to that patient's demographics to understand that disease progression appropriately and what's driving that. So we can get to more preventative elements before we get to those more acute issues. And lastly, we do provide those lifestyle insights and nutritional and dietary and other insights appropriately so that they can feed in not just at a general level, but specific to the lab results and the most pressing issues that the lab results show. So now all of a sudden, it's not just a generic, hey, let's eat better and sleep better, et cetera, and exercise more often, which of course is motherhood and apple pie. But more specifically, wait, for these specific biomarker and these issues and these major concerns, here are the very specific set of things to go do as a result of that, based on all of the complementary to medicine sciences out there, the nutritional science, the hydration science, the sleep science, et cetera, what to go do for that specific individual. Once again, the lab results are a perfect magnifying glass of what's happening inside the body. We are able to harness all that information appropriately and put it at clinicians' fingertips, but also patients' fingertips. Because now the process has changed. Because now that we share this report back into the EHR, into the system, that's being shared with the patients as well as whichever clinicians are looking at it. That's now driving a completely different conversation when the patient is having the consult with the provider. What do I mean by that? Historically, you think about a 10-minute visit, 6 minutes is getting to a diagnosis, 2 minutes to 3 minutes focus on treatment, and then 1 to 2 minutes just to connect as human beings. Well, when we get to that diagnosis piece early, instead of spending 6 minutes getting there, we now get 3 minutes to get to that. Now we get 5 minutes to really talk through the treatment, what to go do about it in a way that now is self-empowerment for the patient. And in that process, now we're driving better adherence to care plans overall. And then instead of 1 minute, really double that time, 2 minutes to really get to know each other. That human connection element is so important. So we're sort of changing the model overall with the most basic tool that's being used out there for more than 100 years.
And it seems like it's more of a consumer trust thing. There's a lot of mistrust, distrust, and I'm not talking COVID. I mean, it's just people want to be taken care of and they want a real snapshot. So as a consumer, it just seems like it's a no-brainer. So I imagine this evolution of this product came from your practice, Dr. Bhandari. I mean, you were working with all these patients, and this is something, if it wasn't from this, you'd need this sort of technology, correct?
Yeah, I mean, it started with, I came into medicine around the time that EMR became a requirement. So I came from the paper charts where we're still spending time with people, chatting with them, figuring things out, to like quickly, we got to protocolize everything. We've got to see lots more people. Our reimbursements are going down. So just churn, churn, churn. So as a human being, you're like, okay, how do I survive in this craziness? And what I found was that in this shift, we were like focusing a lot on, okay, here's a bunch of tests I can order. I'm going to look at the screen. I'm going to quickly try to size this up in like seconds and then move. But what got lost and what I saw was that providers are freaking out on the inside, right? I mean, when you really are empathetic, you are like, you feel for that human being. And as a primary care provider, we don't actually have a lot of procedures that we get paid for. So our tool is chatting with people and figuring out their storyline, and we take care of the whole family. So you're thinking from the lens of, I have a pregnant woman to like, and I'm the primary care provider for it, to that baby who's born, and I'm going to care for that one, to the grandmother. And all of a sudden, it was like, I think what I freaked out was I wasn't just going through this experience as a physician, I was also dealing with sick children. And I didn't know what was going on. And I knew that if I would prescribe the same thing I would train to prescribe to my children, I knew the outcomes. I didn't want to do that. And so I think I took from two different lenses where I recognize what's getting in the way. And from that point, I was like, I can't fight something that is just, I don't know how to do that. But I know I can connect with people. The data is really important. I am a scientist at heart. I want to understand this data. And I want to really harness in on medicine started with connecting of people. And our job was to fundamentally to get out of the way as they were helping them heal, but not to cause harm.
Mm-hmm.
And what we've shifted in this trajectory over my 25-year career is we've lost this connection.
Mm-hmm.
And we actually are structurally designed where we don't have the real responsibility over making sure the solutions we recommend are safe for patients, right? We are protected by our malpractice, by our institutions. And I'm not saying it's just what it is, right?
Mm-hmm.
But we've become very defensive, institutionalized style that has moved away from that human connection. And that's what patients now, I think what's changed is that they're not willing to put up with it, right? They're putting their money and their time with what matters. And that really changed in the pandemic. And so I think that from a personal struggle of not being happy with providers all burning out, including me for a long time, and really struggling to figure out how do I help my children who are very sick from a young age, and just looking anywhere. What I found was with those big elements happening, I then shifted my focus, right? I went to focusing on what do patients want, take out the noise because I'm struggling. And if I can do that, I can harness in the root cause, go as far upstream as I can. And how do you create a financially viable business, right? Because that's going to create a platform where consumers are really happy. And the consumer is me,
Mm-hmm.
other providers, patients, but we also have to thrive. Patients, one of the biggest stressors in the United States is getting sick is really expensive. And we kind of dumb it down to oh, you've got heart disease. Oh, you have diabetes. But our solutions are very expensive in the sense of they drive up the healthcare burden and they drive up people's cost. And when you're a provider and you don't really internalize that the solutions you're recommending from diagnostic tests and your drugs, what's it going to cost this person? Not just them, but their family, right? And from a family doctor, I think from the lens of this is a mother, this is a daughter, this is a sister, and she is fundamentally driven because she's caring for people. And coming from that lens is how I've approached how do we change it up? And it's totally possible.
I mean, the other part of this, to be clear, is you've spent the last more than a dozen years, 15 years, really focused on very complex chronic diseases where these are big medical mysteries that you've been dealing with. And as part of that process, it's not as simple as, oh, great, my simple example, LDL cholesterol level is high and everything else is sort of looking normal. Great. That's a very simple or a more simplistic approach. But when you've got many issues, how do you bundle it together? And I think that's part of, when you talk about freaking out inside, part of it is this medical mystery and this scientific mind you've got to dig in. And you've got case after case after case where it's.
But I mean, let's take an example, right?
Yeah.
If you really think about most of us, we're all complex, right? We've got these complex stories and we're presenting. So, you've got somebody who comes in and says, I have headaches all the time. And the woman says, yeah, and they happen to come around my period. And I also end up feeling really tired and I can't sleep and I'm having hot flashes. That's a lot of different things going on. So we're trained to be just narrow it down to one thing, pick that thing, and then boom, the solution is tied to that one major description. But if you step away as a scientist, you say, that doesn't make sense. Humanly, we want to reduce. That's how we operate because it gives us a focus point. And then we hold on to that focus point and we say, okay, all my symptoms are menopause because I'm 48 years old and that's what fits all the buckets. But everybody is labeled as menopause for having hot flashes and feeling tired and not sleeping well and being moody. You're and the solution is just this. And I think that coming from that perspective, being no, this is complex. But what I know is the saving grace is the data. That for me is the data, if it comes from a scientific point of view, it clearly is going to harness, here's what the data means. And then help me focus in on what should I hold on to, right? Not the diagnosis, because if you look at it, someone could say, okay, headache. Oh, well, you've got chronic migraines. Oh, well, you've got polycystic ovarian syndrome. Oh, you've got, you're just menopause. Oh, you've got irritable bowel syndrome, right? Depending on what you say, you're going to get all these different labels. Or the worst is you say, you just got anxiety. It's in your head. And that person's it's not in my head. So when you can separate that out and say, look, I need to have a bunch of labels. That's really important. But please tell me what's going on. And what I found was that I was really frustrated that how do I organize all this data? I mean, if you look at a standard lab, there are so many biomarkers. How do I make sense of every single line item from how I was trained to say, okay, I'm finding anemia and I'm finding high LDL and then I find a high TSH. They're totally different, actually, diagnoses, and they're totally different solutions, right? So I got to pick based on my prioritization. But that's not okay for the consumer who's like, how did you decide that that was the first priority versus the other doctor who said, oh no, his priority is anemia? And so I found that, like, from a personal struggle, and the patient was like, you're the expert. You need to know all of this and do all of these calculations and just tell me, and then give me solutions that drive immediate results. I was like, the bar is really high. And so part of the birth of Advanced Health Academy was like, go upstream, make it easier for me as a clinician and for all the other clinicians who are like, harness this data and tell me, what are we focusing on in terms of the organ? Where is it rooted? What's the actual biomarker that's the scariest? Because we know that things are happening and we want to, like, prevent that catastrophe, right?
You know, this call has been really helpful. It sort of helps me, and I would imagine as the audience, the process, because, you know, great. Now I can go to functional health. I shouldn't mention all the names, but I can get all these lab results. Now what do I do about it? And so, you know, and I already did my homework on that, and that's why I didn't sign up, because it's like, okay, it's not going to solve the problem. And I think, anyway, that's not about, you know, it's the fact that you've shared openly as a clinician the challenge of now having, through all the data points of Academy Health, you know, Advanced Health Academy, of those algorithms, if you would, all those different ways to bucket in a way, like, I don't know what it would be called, if it's a diagnostic sort of methodology or some way that isn't then connected to the reimbursement, or if this guy's a disease doctor for this or whatever, or his referrals or whatever. So it just seems like the approach that you sought after is kind of I don't know what you would call it, but it just seems like the way healthcare should be, you know? So
Well, it's very simple. I think it is about take out the cognitive biases, and it's really hard to do. And as a scientist, that's really, if you come from that scientific lens, which we're all in a sense scientists, we're looking at data is just in general in your life, right? And you're scientifically saying, what is this? Just identify it. Then why is it? Okay. And now what do I do with it? When you go from the human lens, the human will take the data and quickly reduce the data into, oh, well, my prior experience identified this data point, translated to this data point. But that doesn't make sense, because that's my perception of the data. But what about when you're taking care of patients? They each have a different perception of the data. So we can't apply my reductive perception of the data and then apply it to everybody else. And that's kind of where also the research is, that it reduces the interpretation of data in a very reductive manner.
I mean, just doing it differently, right? As human beings, we've got experiential bias, we've got recency bias, we've got confirmation bias, we've got, the list goes on. I'll put it that way. And so the question here for us, as we were building AHA from the outset, was how do we make sure we are surfacing the science appropriately and taking the best by every discipline, pulling it all together, so we're not sort of got blind spots in different, call it, medical areas, cardiology, hepatology, et cetera, but instead, how do we think about this across all those specialists coming together and have one consolidated view based on what that root cause is and what's driving that? And I think that has been something that's been unique and special in what we've built out here. And I think we need more of across all of medicine to help patients live their best lives.
So what might help, at least maybe the audience, definitely I would say me, as I understand, is, so you take this kind of open scientific approach, you have the data. Now, how does that plug in with the treatment plan? Obviously, can you share maybe one or two stories?
Yeah, I'll give you a case. Patient, 56-year-old man, 20 plus years of high blood pressure, high cholesterol, obstructive sleep apnea on a CPAP machine, morbidly obese. Seeing this person for many years, we, regularly get labs done. I'm already biased in terms of, well, he already has all these issues, right? And this is just how he feels. And so with routine labs, he always says, well, I'm tired. I don't, I sleep 8 hours, but I still never feel rested. And it's like, okay, I don't know, I don't know what else to do with that because we're managing his meds. But when we took labs that before AHA, I would just quickly scan it and say, yeah, it looks like the numbers are okay, or you're stable, or we'll tweak this, or we'll tweak that. But then when I brought in AHA and I looked at the data, and it all of a sudden was like, oh, no, if you look at the trends report of his labs, he's like, wow, there's some major liver issues. Like this guy's got fatty liver disease. And then it actually quickly harnessed, oh, there's a major cardiac issue. I didn't have any other data from the patient, right? Because he was just feeling the way he is. But we know with cardiovascular disease, most MIs are silent, right? You don't actually have the classic story of chest pain, shortness of breath. When you have many patients who are obese, they have some baseline issues of, I can't breathe really well, but they're just like, well, this is just my baseline. When we took those AHA results and I knew exactly how to understand, oh, I have to focus on this, that really changed the trajectory because I think without it, I wouldn't have expedited this patient, getting him to the cardiologist as fast as I did, and actually being very precise on my consult note, saying this person has this, major cardiac marker that's actually really concerning, and he's got these other issues. It looks like, he may need like a catheterization. Like we need to figure out what's going on. So it expedited it. That patient, because of it, was able to get a stent put in probably 18 months prior than when we would have other found it. And it not only did he have better results in terms of post-op, but that he was motivated because we prevented a major catastrophe. And with that, it really helped him not only feel better, but now all of a sudden, when I was working on dietary and movement, he was motivated, right? So it shifted the behavior from the fact that the data was made very apparent to him. And it was also the cardiologist also agreed, oh yeah, we would have all missed this, right? And I think the outcomes drove some amazing results. So it motivated the patient to actually see, wow, this is what my data is saying.
So my worry is then what the heck's happening right now when I go to see my primary care right now?
I mean, they're a human being, right? They're doing the best they can, but they have to, if you're getting labs done, for example, we have seconds to quickly analyze it. And in those seconds, just like any human being, you're going to look at only 3% of the data. So you're going to miss 97%. That means 90% of data interpretation may be skewed. And so with that, that means that whatever output you get is possibly biased by that human being. And so I think consumers, you want to know what your data says.
Well,
and you want to have that in conversation where you can say, hey, together, this is a mystery, but we're going to go on a journey to help actually feel more empowered with the data has surfaced, these insights. Now, what do we do together?
So can people with a primary care, can they access that lab, your AHA through consent? How does this work? It just seems like I see a doctor and they they do my labs every year and it's like, all right, I have high cholesterol. I've known that, whatever, but it's just like, that's been going on these last 5 years, so, and imagine I'm not alone.
Unfortunately not. There's a couple of ways to access it. So number one, physicians and providers can do that right through their EHR. So that's a possibility. But secondly, as patients, we've got consumer-facing applications, mobile applications, web applications. So you can go to ahealthacademy.com, sign up for an account and do it yourself with your own lab results and go take pictures of it, take screenshots of it. If you have PDFs of it, great, upload it. We will analyze it and provide the interpretation directly to us as the patients as well. So not just for the providers, but also for us as patients to better understand what's transpiring. So that part's easy. The other thing I would just want to turn back to, what you're saying is, clinicians are doing an amazing job. There's so much information they're trying to grasp in such a short amount of time, dealing with specific patient issues. They are, with a limited amount of time, they're focused on the most pressing issues that are happening acutely and immediately. And so when we're asking, hey, what are primary care physicians doing? They're focused on those acute, immediate issues. And if they're not acute, immediate issues, we've come to really redefine health as the absence of disease in this day and age. Not in terms of, hey, we've got maybe developing disease, how do we prevent in that? And the healthcare models and systems, it's not that any clinician has gone into medicine to go make it that way. It's just that has become the reality of the business model. And so it becomes harder and harder for clinicians to have the data at their fingertips to be more preventative and help drive that more proactive situation to avoid those major acute issues. And that's what we're trying to help the world get to again, because it's what we all want.
Yeah, it seems like any patient, any person that hears this kind of call, they would like, well, are you, doc? You know, I love you, great. I have respect for your profession, but are you checking doing the AHA check on me? You know?
Yeah.
Yeah. Well, yeah, they have to reach out to actually be able to integrate that into their system. Right?
Well, you know, as we wrap up, I'm so glad you guys have come here. I know I hope to have you on again to talk about. I mean, you guys are not only are you're a clinician, you're both entrepreneurs. You're doing a lot of different things. So, really hope that we can have you on again soon to talk about some more of what you're doing. But before we finish today, as we wrap up, is there anything else we'd like to capture here today?
I'll just say very clearly, there is a better way out there. And I've got boundless optimism and hope of where we're heading overall. There are major issues and there's shortcomings, and we need to tackle those together. And as a society and as individuals, we have the ability to do that in a way that has never been there before. And I am very optimistic that we can get to better healthcare outcomes collectively working together, either both at a system level, at a societal level, but also at an individual level. And so, you know, we've got the capability to do that now. Now it's a question, let's go do it. And so I'm more than excited about that this future that we live in today.
Yeah. Yeah. I think it is going to take a community of us to really come together to change things, because when we look at the landscape within the next 5 years, you're going to have 25% of healthcare providers who've just voluntarily left. Their situations are getting worse, where they have long, inflexible hours, reduced pay, and chronic stress. They are patients, and they need that support. They're not the enemies. They are struggling too. And so I think collectively, from an empathetic lens, it's really easy to complain and criticize, but that's actually created more of the models that we're in terms of these short-term solutions that get applied in a destructive manner. And I think that if we collectively come together to realize we're all in this together, that's why, you know, Nilesh and I have really devoted our lives from the lens of we've gone through it. Our children have gone through it. We've transformed patients' lives, and we want to take this out on a larger scale, because we know that the rates of these epidemics are just skyrocketing, and they have been since the 1980s and beyond, and that's not going to change. And so I do fundamentally have faith, though, that when you hear that calling within yourself from a loved one that you feel for, not for yourself, don't do it for yourself. Do it for that child that's maybe your own child or your neighbor's child, whatever it is. We do it for them. They are our future, and they are, from that lens is why we're doing this.
Well, thank you so much for both of you coming on today. This has been fantastic. I really appreciate it.
Thank you, Michael.
Thank you. Great work too, with everything you're doing and pulling people together, because you're helping to advance the conversation to where we need to be to build the world we want to build. So thank you.
Yeah, no, this is awesome. And so tell us just a sneak peek on our next episode. Would you share a little bit what we'd be talking about next time?
So we are launching an AI-enabled virtual care service that is the solution for curing all 150 plus autoimmune disorders. This is it is the biggest health threat of our time, especially for women who have an 85% chance of developing an autoimmune disorder in their lifetime. And when we are not effectively addressing this, these are the gateway diseases that more than half of them turn into cancers, cardiovascular disease, infertility, and premature death. So when you start hearing heart attack, cancer, think autoimmunity, think the women and the children who are truly at the highest risk. And we are focusing on empowering all of us collectively.
And
Well,
with a model that is completely,
sorry.
and with a model that's completely beyond just clinical medicine, but thinking about whole person integrated care, which is highly effective because Payal has done this for many, many years with thousands of patients and has seen amazing results. And so we're taking that and scaling that to a level that is now accessible to everyone.
Yeah. Well, we're not going to be able to stay on today and do it. We'll have to we'll keep everyone waiting. I'm waiting. I wish we could go forward today with that. Super exciting. Really keep up all the work, and I look forward to having you guys on next time for that.
Okay. Thank you, Michael.
Thank you so much.
Awesome. Thank you.
Okay.